Arthrodesis, hip joint, includes obtaining graft. To perform an intra-articular arthrodesis, the physician makes an anterior iliofemoral incision. The sartorius and rectus femoris muscles are detached from their origins. The iliopsoas is reflected from the front of the hip joint. The physician dislocates the hip anteriorly. Cartilage is removed from the femoral head and acetabulum down to bleeding cancellous bone. The physician packs the space between the surfaces of the femoral head and acetabulum with cancellous autogenous bone grafts. An example of the position in which the hip may be fused is 30 degrees of flexion, 0 to 5 degrees of adduction, and 10 degrees of external rotation. The physician may use compression screws to increase the stability of the fusion. The sartorius and rectus femoris muscles are reattached. The screws are placed through the femoral head and into the supraacetabular area of the ilium. The incision is repaired in layers with suction drains. The limb may be placed in a single spica cast or in balanced suspension. Arthrodesis, hip joint, includes obtaining graft, with subtrochanteric osteotomy. The physician harvests a bone graft from the patient's iliac wing and crest and closes the surgically created graft donor site. The graft is positioned so it spans the anterior aspect of the hip from the pubic ramus to the femoral neck. The graft is secured with cancellous lag screws. The arthrodesis is performed so that the hip is in 10 degrees of external rotation, 0 to 5 degrees of adduction, and 30 degrees of flexion. A subtrochanteric osteotomy, bone cut, is made just below the lesser trochanter. The sartorius and rectus femoris muscles are reattached and the iliopsoas muscle is repositioned. The incision is repaired in layers with suction drains. A 1 1/2 spica cast is applied. Arthrodesis with distal radio-ulnar joint and segmental resection of ulna, with or without bone graft, e.g., sauve-kapandji procedure. The physician performs fusion of the distal radio-ulnar joint and resection of the ulna, sometimes using a bone graft. The physician makes a dorsal, curvilinear incision over the distal radio-ulnar joint. The extensor retinaculum is reflected, uncovering the extensor carpi ulnaris and extensor digiti minimi tendons. The capsule is cut and reflected, exposing the ulnar head. A small lamina spreader may be used to view the sigmoid notch of the radius. The periosteum is stripped from the ulna just proximal to the articular surface. The dorsal radio-ulnar ligaments are stripped sharply. If the distal ulna has been removed, or part of the distal ulna is missing, the remaining portion is decorticated. The radius is prepared by making a notch in the ulnar aspect where the distal ulna can be slotted. The ulna is manually compressed into the notch, holding the forearm in 10 to 15 degree pronation. The physician drives a Kirschner wire from the ulna into the radius and 2 compression screws from the outer aspect of the ulna through both cortices of the radius. The extensor retinaculum is reconstructed and the skin is closed.